start with our CVA video. So, cerebral vascular accident. I always say cardio, but cerebral vascular accident. All right, so let's talk about just some of the common risks and slash etiologies. So the non-modifiable risks are age, family history, if you have a personal history of a prior CVA or a TIA, even counts. Diabetes, hypertension, carotid stenosis, Afib, high cholesterol, coronary artery disease. Okay, so Afib is a really big one of the major causes of stroke. And that's because if your atrial fibrillation is not being treated, then usually you will throw a clot to your brain. So in atrial fibrillation, if you remember, if it's not being treated correctly, and if they haven't done an ablation or something like that to get rid of the ectopic beat, if it's continuing to fibrillate the top of the heart, so the atria is fibrillating, right? Which means blood isn't being pumped out of it. It's just kind of quivering, right? And so when blood just sits around and doesn't go anywhere, what happens to it? It clots. So if you make lots of clots, then those clots get shot everywhere, and mainly to the brain. So that's why people who have atrial fibrillation have to be on some sort of anticoagulant therapy if they are always in Afib. Okay, if their Afib has been treated and corrected, then that's different. But if they're always in atrial fibrillation, then they have to be on anticoagulation. Okay, so the next risk factors have to do with our lifestyle choices. So being sedentary, if we smoky, right? If we drinky, ETOH or alcohol, if we are obese. Okay, so those are the risk factors. Okay, the types of strokes are, so just really quickly, a TIA isn't technically a full-blown stroke. TIA stands for a transient ischemic attack. So let's talk about that for just a minute. We have a clot in both our ischemic stroke and our TIA. But in the TIA, it's moving. In the ischemic, it's stuck. It's not going anywhere. So usually the number one sign or symptom that you're having a TIA is that your symptoms resolve. And they usually resolve within 30 minutes. Obviously, you know, there's exceptions to every rule, but they usually will get better within 30 minutes. So that's how you know that it's most likely a TIA. If they don't get better, then it's probably the actual ischemic CVA. So imagine you have a clot in your brain. This is the TIA kind. And that clot is moving. So it moves, gets stuck for a minute. While it's stuck, that's when you have symptoms, right? Because there's no blood flow. And then it moves, and then your symptoms improve, and then it gets stuck for a minute, right? So that's how those symptoms can possibly come and go, okay? Now with ischemic, it's stuck, it doesn't move. This represents 85% of all CVAs, so kind of the more common one. We used to call it thrombotic, but now it's relabeled ischemic. Then we have the hemorrhagic type. Only 15% of CVAs are hemorrhagic, and that's the leak or like kind of an explosion, right? So you have that hemorrhagic vessel that either is under too much pressure for too long, or it balloons out, right? Like in the case of an aneurysm. Okay, so now we have signs and symptoms. So we have speech changes. What types of changes are we going to see? Well, I mean, they could have no speech, right, at all whatsoever, or they could have some garbled, sorry about my marker, they could have garbled speech. They could have like a word salad where it's just a bunch of words all together that don't really make any sense. So lots of different speech changes, okay? And then we have weakness. Usually that happens in a lot of different places, right? So mostly the face, right? And then our arms and our legs. So we'll get extremity weakness and weakness in the face, one side or the other. Now, they also have a change in LOC. They could or could not, it just depends. Or altered mental status is the other kind of acronym that we use. So also vision changes, so changes in our vision. Sometimes they'll have the hemianopsia, right? where if we have, here's our eyeballs, okay? Excuse the crude illustration. So here's our eyeballs, and this is our field of vision on our eyeballs, and what will happen is with hemianopsia is they'll lose the vision in one eyeball. One side of that eyeball, excuse me, not one eyeball, but one side of that eyeball. So in this, it would be bilateral, left-sided hemianopsia, right? Hemianopsia, okay? So that's one of the vision changes. Obviously, you can have blurry vision as well, but we won't get too much into that. So then you can have a headache as well with a CVA. Sometimes it is more common, and you can have it with ischemic as well. So when we have that thunderclap headache, in the textbooks, that's the word they use to describe it, is the thunderclap headache. People will also describe it as the worst headache of my life. It is not a chronic headache that came on gradually, but rather sudden. A very, very sudden headache. So I usually ask these questions if I'm triaging a patient that I'm suspecting of a stroke, or even if they just have a headache. I'm going to ask things like, what were you doing when the headache started? If they were bearing down in any way, like when they're doing number 2 in the bathroom, and all of a sudden the headache came on like a big thunderclap while they were trying to go number 2, that's pretty ominous. The other time when you can have a nasty, huge thunderclap headache is during orgasm. So you need to ask that question as well. What were you doing when this happened? Were you having sex? Were you on the toilet going poop? So some interesting questions to ask your patient. Also, you can have a little bit of nausea and vomiting, or it can be rather severe. So, all right, so let's talk a little bit about the FAST check, or so it's kind of like the little layman's one that we put out for everybody. They make billboards, they put them up in hospitals, they put them up in schools, community centers, to try to educate the public on how to recognize a stroke. Because in a stroke, it's all about the time. And the quicker they can get to a stroke center and get treatment, then the better chances that they have of having, return of all of their functioning. And they won't have any permanent deficits, okay? So that's the huge thing with CVAs, is time, all right? So with the FAST scan, we want to ask the patient whether we look at their face. So do they have a droop? This is a really simple, quick, easy kind of test for a stroke, all right? EMS does this a lot as well. And then they'll also look at the arms, okay? So this is when you have the patient smile, right? Smile, show me your teeth. There's several ways you can have them do that. Okay, now arms, you have them, that's when you have them do Superman arms. Stick your arms straight out, and then you kind of see, which arm, if any, is weaker than the other when they stick them straight out. So I always have them do Superman. Okay, and then the other one is speech. So here, again, similar to the symptoms, we're just checking for symptoms, and this is a really good way we can teach lay people. Do they have a droop? Is there something the matter with their speech? How are their arms? Do they have strength in their arms at all? Okay, so speech, you're just looking for any sort of changes, okay? And then time is a huge piece of it, because if it's a ischemic stroke, if there's a clot in the way, and we got to give them the clot buster, otherwise known as tissue plasminogen activator, or TPA, they can't have it if it's been more than 3 hours. Now, just know that there are some facilities and a lot of stroke centers that are now treating some types of strokes as long as 6 hours, and then there are some macroembolisms that they're able to retrieve with interventional radiology at more than 6 hours up to 24 hours. But the general rule is usually under 3 hours. That's when we want that time from the symptoms start till we get treatment. So we want that to be less than 3 hours. We'll talk about that a little bit more in a minute. Okay, let's look at our, let's see, GCS. Oop. The camera up. Move this over. Back. Oh, let's just do this. Okay. So really quickly, I'm just going to go over the GCS, which is the Glasgow Coma Scale. I'm assuming it had its origins in Glasgow, right? So that just has to do with an assessment for overall level of consciousness. You will see Glasgow and you will hear a GCS score given a lot by EMS. You know, with head injuries, trauma, like a lot of different things. So it's not specific to stroke, but this is kind of a good time to teach it. And we don't really stress it a ton in stroke because we really want to stress the actual neuro check and the specialized neuro assessment. So I'm just going to spend a couple minutes on this. So first we look at eye opening. So when you walk in the patient's room, are they opening their eyes spontaneously or are they asleep? So if they open spontaneously without any noises or anything, then they get a score of a 4. Okay? The total is out of 15 based on 3 things: eye opening, verbal response, and motor response. So if they open spontaneously, great, they get a 4. All right, now if they only open to sound, so say I walk into my patient's room and I have to tap them on the shoulder, or I have to, you know, take their arm and put the blood pressure cuff on them if I'm taking vitals, if I need to hook them up to a monitor, and then they wake up, right? Then that is sound. I'm sorry, excuse me, that would be with touch. So, excuse me, back up. So with sound, I would have to go into the room and actually say something to the patient. Call them by name, ask them a question, and then if they wake up, then they get a 3, right? Now the next one, sorry, I was getting ahead of myself, is with pressure, pain, pressure or pain. So I'm picking their arm up to put a cuff on them, you know, I touch them, whatever, tactile kind of stuff. They get 2. And then if they don't have any response with any of those things, they get a 1. So no response. And then sometimes it's not really applicable. You can't use a Glasgow in certain groups of people, right? So anybody under general anesthesia is paralyzed. And so even if they wanted to move, they can't. So you can't, so anybody intubated and, you know, under anesthesia or, you know, on some sort of medication and sedation to keep them under so that they're not waking up and grabbing onto the tube, obviously this is not going to apply to them, okay? Comatose patients, not going to apply. All right, so then we have a verbal response. So if they're alert and oriented times 3, then they get a 5. Cool. If they're confused, right? So if they fall out on one of those, let's say they know who they are, they know where they are, but they mess up the time and the situation, right? Then they're confused, okay? If they only give you words when you talk to them, then obviously they get a 3. If they only give you sounds, right? So that might look like this. You are trying to talk to them, get them to open their eyes, and they only moan, or, you know, they just make sounds. So the words might be, hey, you know, if they're saying no, stop, that kind of stuff. They're still able to make words, they're just not, you know, totally with it. And then none, no verbal response whatsoever, they still get a 1. And then if there's, they get none, obviously, if they don't apply, right? So that's our intubated population, general anesthesia, stuff like that. All right, now if with motor, we want them to obey commands, right? So that would be if I ask my patient, hey, can you open your eyes for me? That's a pretty basic lizard brain command, if you will, right? We would hope that most people, if they hear you say open your eyes, they'll know what to do, okay? So pretty basic command kind of stuff. Can you squeeze my hands? You know, can you wiggle your fingers? Things like that. All right, and then if they only localize to a stimuli, so their motor response would be to localize. Well, what does that mean? So that looks like if I'm gonna put a blood pressure cuff on my patient and they go, and they pull it off. Or they might move away from me. that kind of stuff. Or they might, grab it and take it off. Or they have a nasal cannula in or a mask, and they go to pull it off because it's bugging them. So they get a point for that. 5 points for that one. Now, if they do flexion, and this is normal flexion, so don't get this confused with abnormal flexion. So let's say they don't localize to what you're doing to them, but they kind of flex their whole entire body, get into a ball, they flex their arms, they flex their legs, that's normal flexion. Now, abnormal flexion is what's known as decorticate, right? So that's when you do some sort of painful stimuli to them. So sternal rub, and then they do this. So it's this motion, right? So normal flexion is this motion, right? But abnormal flexion tells you that there's something the matter, in the actual brain itself, in the central nervous system, and that's this motion, right? So kind of a bit of a distinction, okay? And then if they have extension, right, that still gets a 2. Ooh, let's spell it right. So if they have extension, that looks like this. That's what is known as decerebrate, right? Where we extend our arms, and then you extend that wrist joint back. And it obviously would be bilateral, okay? But that's what that looks like. So it's the straightening of the arm, and then you flex that wrist joint back. And then no response, okay, obviously, and then non-applicable to our intubated anesthesia patients. Okay, so that is GCS, kind of in a nutshell. So these checks have to be done every 15 minutes. So if you're a stroke center, every single nurse has to be trained on how to do a neuro check specific to a CVA, okay? So this is a very kind of more in-depth neuro check. This is not the same as an NIH stroke scale that the providers do at the bedside. A little bit different than that, okay? But this has to happen every 15 minutes during the entire stroke. From the time that they roll in the door, whether it's on an ambulance or whether it's in a private vehicle, and once that stroke or code stroke is called overhead, that starts your clock. And so you have to do every 15-minute neuro checks until you transfer them, or until they're downgraded or the stroke is ruled out. But even then, if the stroke is ruled out, you're still doing them every 30 minutes and then every hour. So, all right, so let's talk just acutely what these neuro checks look like at the start. So at first you're going to start out from the head, and I will make another video that's with an actual patient doing a neuro check so that you can see how it's done from start to finish. So we do pupils size, right? So use your pen lights or your phone. Reactivity, we want to know symmetry. Are they the same size? Do they react? How many millimeters are they? So once you get more experienced, you'll be able to look at pupils and kind of automatically know a ballpark of about how many millimeters they are. But the pen light always has a little measurement on there, so you can kind of go off of that. But you need to know the millimeters in this instance. We need to know left and right. Are they the same? Are they equal? Is the right bigger than the left? All that kind of stuff. Do they react? So that's kind of our PERLA, but a little bit more in depth. Then we want to know, do they have a facial droop? So you need to ask the patient to smile for you. Some patients don't like to smile. Obviously in a stressful situation like that, when they're under scrutiny for a stroke rule out, they're worried. And so sometimes I'll say, if they don't want to smile, I'll say, can you show me your teeth? And so I just say, show me your teeth, nice and big, great. And then you're going to note, is the facial droop on one side or the other or not at all? Okay, so is it on the left side, right side, whatever side? Okay, and then you need to note that. All right, and then we have to figure out, are the eyebrows involved? Usually they're not involved in a stroke. Okay, has to do with the facial nerve. And so usually they'll be able to move their eyebrows. That's how we differentiate between a CVA and Bell's palsy. In Bell's palsy, the eyebrow will be included in that droop. Okay, so usually with a CVA, the eyebrows are not involved. So we're trying to rule out Bell's palsy, okay? And then our speech quality, we want to know, is it garbled, is it slurred, kind of help describe it. Are we just getting 1 words, 2 words? What are we getting? And then you need to have them, you need to be able to evaluate their speech, and you can't really do that properly or adequately without having them repeat a phrase back to you. You can borrow my phrase and use it forever. You can come up with your own phrase. It just has to have at least 5 to 7 words in it, and it has to be the same phrase every time you do that 15-minute neuro check. If you change up the phrase, now you've added a confounding variable, and then now you have no idea how their speech is, right? So you have to keep it the same so that you can have that control and accuracy. All right, so my phrase is, you can't teach an old dog new tricks, okay? You could do, my dog, I took my dog for a walk today, right? Or I walked my dog down the street, things like that. Come up with a phrase, 5 to 7 words, right? Or you can use this one. And then you kind of note, were they able to do it all together? Did they just get a couple words? You can add that in your note. Now we're going to do our upper extremities first. I like to group together the strength, the motor, and sensation into one assessment of the upper extremities. And then I like to do strength, motor, sensation in the lower extremities. So I like to do everything in the uppers and then move to the lowers. That way you're not bouncing back and forth between the arms and the legs, okay? So strength, we have them raised. So just like with the fast scan, this is more in depth, right? So you have them raise their arms straight out in front of them. See if one's drooping or the other, right? So if this was your patient, if I'm your patient, then you would note that they have significant weakness in that left arm, right? Are they able to lift it off the bed? You want to note that. Are they able to resist gravity at all? So can you hold it up and then do they drop it? That kind of thing. So you want to have them raise their arms, okay? If they can't raise that arm, you want to see to what degree. Like, can I hold it up and then they drop it? Are they able to maybe lift it up, off the bed a little bit? So that's our arms. Excuse me. So arms. Okay. Now with motor sensation, with motor, we want them to squeeze our hands. So strength. Oh, excuse me, I have it all completely reversed. Okay, so with motor, we want them to raise their arms. Okay, so motor, you're going to have them raise their arms, see if there's a droop, if their arm drops, if one's weaker than the other, if they can even lift it off the bed. Strength, we want to have them squeeze our hands. And you need to do both hands at the same time so that you can compare if one grip was weaker than the other, okay? Then what we need to do is evaluate sensation, okay? So can you feel? And you're gonna do this. So you wanna do the lower part of the arm, upper part of the arm. Can you feel me when I touch? 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 Are you having any tingling sensations? So you need to ask about tingling. Okay? So can you feel, and if they're having pins and needles or tingling. Okay? Now we do the same thing in the lower extremities. So I got them reversed in the lower extremities too. So with strength, you're going to have them do the gas pedal. I would just have them do one thing. So you can have them do gas pedal, or you can have them pull against you and do that the dorsiflexion. But I would just have them do one or the other. Don't confuse them, and you don't want to take tons of time. You should be able to do this neuro check in under 5 minutes. So you want to do the gas pedal or the dorsiflexion. So choose which one, but don't do both. And then motor, you want to see if they can lift that leg. So you want them to lift it straight legged right off the bed. Don't have them bend it and lift it because that's weird. You can't evaluate it properly. Have them lift it straight off the bed and see how far. So raise or lift, right? And then sensation, same thing. Are you tingling in that area? Can you feel me when I touch, right? So on their legs, can you feel? Can you feel, right? So feeling, and then the tingling. Okay, now we want to know if they have a headache, but we also want to grade that headache from 0 to 10. So they need to give us a number. If your patient is nonverbal because of the symptoms of the stroke, then you're going to have to get a little bit creative, right? So I had a patient, and I actually did sounds. I had them make sounds. So she was able to make a sound. And so what I did is I said, okay, so what I'm going to do, because I didn't have time to write anything down or have her point to it, she was weak, anyway. So what I did is I said, I'm going to count from 0 to 10. When you hear the number that your headache is, how bad it is, that number, I want you to make the sound or say yes or blink your eyes, right? So then I say 0 and wait, and then 1, wait, 2, wait. Okay, so obviously it's not going to be that difficult if the patient can talk or at least say, one number, okay? And then obviously you can have them draw the picture of the number scale, have them point to it, but this just makes it a little easier as far as you don't have to pull out paper to do anything. You can do it all, verbal. So headache out of 10, whatever they are. And then we want to talk about vision changes. So this is when you stand at the end of the bed. So I'm going to stand at the foot of the bed. We'll pretend the camera is my patient. And then I'm going to stand in the middle and say, are you able to see me in both eyes, okay? And they're going to look at you with both eyes open, okay? Then I'm going to move over to the side. Can you see me here? Then I'm going to move over here. Can you see me here? Okay? And have them say, are you able to see me on this side, and in the middle? Okay? Then I need them, so this is where you involve another nurse or a tech or somebody or a family member. Have them, close one eye, and then you do the same thing. Can you see me over here? Can you see me in the middle? Can you see me over here? And then you have them cover the other eye, right? And then you do the same thing. Can you see me here? Can you see me here? Can you see me here? Okay, so that's how you're going to evaluate that if they actually have that hemianopsia, okay? So what field of vision they can't see. So if they can't see, you guys are facing me, so if they can't see on their left side, when you stand over here on their left side, right, they won't be able to see you. And so that's kind of your hemianopsia, all right. So that's kind of our vision changes. So that's where we kind of dance around the end of the bed. Moving, standing around the end of the bed, okay? All right, now, basic CVA protocol. All right, now, if it's a stroke center, most stroke centers nowadays have what's called direct to CT protocol, okay? That means that if the patient is brought in by an ambulance and EMS is able to do that fast scan and route and they're positive, then they can actually tell the facility before they even get there that the patient is a possible stroke. So what happens is that patient does not leave that ambulance bed, right? They'll get into one of our hospital beds, but they never go to a room. They go straight from the ambulance straight to CT, okay? Because the time from when the patient walks in the door to when they get that first non-contrast CT has to be under 10 minutes, okay? Sorry. So we have 10 minutes. We have 10 minutes to get them to CT from the time that they roll in the door until the time they are actually shooting the CT. So that doesn't count moving them to the CT bed, getting them all arranged, putting their lines in the right place, all that kind of stuff. So, that time goes by pretty fast, which is why they started doing the direct to CT protocol. So it'll look like this. The provider, the charge nurse, the primary nurse, and the tech will all congregate in the ambulance bay waiting for the ambulance. Once the ambulance get there, they'll move them directly from the ambulance bed while EMS is giving report over to one of our beds. We will immediately weigh them on the bed, and then you will start your stroke assessment. The physician will get their NIH, and all these things have to be done basically in that ambulance bay or en route to CT, okay? So their last known well is the first piece of information you need. That is the last time they were normal. Whether family's going to report it, EMS reports it from a report from family on scene. Now, if they woke up in the morning having stroke symptoms and they went to bed the night before with no stroke symptoms, their last known well is actually greater than 3 hours, as long as they slept more than 3 hours. So that's kind of where it gets a little sticky. If they went to bed at night and then woke up the next morning, they kind of fall out of that 3-hour criteria, but they might be able to still help them. So anyway, we want that last known well to be less than 3 hours, generally speaking, okay? I know that that number has been moved up to 6 hours in some instances, and then up to 24 hours with different macroembolisms. So anyway, but generally 3 hours. We want to get their weight in kilograms because we might have to give them TPA, and TPA is weight-based in kilograms, and it has to be exact. So we need that weight. We also need to know their vital signs, and so that includes getting them on some sort of tele, you know, whether it's a 3-lead or a 5-lead. So that's our BP included, heart rate, sats, right, and a 10. Okay, so we want all those vital signs. Then we want a finger stick glucose. What? Even if they're not diabetic, we need a finger stick glucose. Why is that? Because if you remember the signs of hypoglycemia, so we are trying to rule out hypoglycemia because some of the signs and symptoms of hypoglycemia, altered mental status, slurred speech, right? Is that starting to sound familiar? So the signs of hypoglycemia mimic a CVA. And so we don't know if it's hypoglycemia or if it's a CVA. If it's hypoglycemia, cool, give them some glucose and call it a day. You saved it. But if it's a CVA, then that's obviously, you know, a totally different thing. So it might be a simple fix like hypoglycemia, or it might be a CVA. But you don't know unless you take their blood glucose. So it's a good idea to rule out hypoglycemia first. All right, we need 2 large bore IVs. One's going to be for TPA, the other one will be usually used for fluids and meds or whatever. Now remember that once TPA started, you cannot poke them anywhere. You can't do another IV. You can't put a Foley in them. You can't put an NG in them. So whatever lines you're going to do, you better get them done before you start TPA, okay? And that's why we do 2 lines, so that if one of them fails, we have a backup, right? And then we have 2 places to give meds. Because one's going to be dedicated to TPA, we can't give anything else in that, while TPA is going. And then the other one, we can be giving medications, to control their blood pressure, different things like that. Okay. And then we want to start our neuro checks, okay? And that obviously is at the top of the list. You want to make sure you start neuro. Now, from the time that the patient walks in the door till the time you actually start TPA, they refer that to as the door to needle time. So the time that you spike that TPA bag and then start it, it should be under 60 minutes, right? So TPA should be under 60 minutes from the time that they arrive, if it's going to be given. And then labs drawn, they just need to be drawn, right? They don't need to be back and resulted. We just need them drawn before they go to CT, okay? Drawn and sent. All right. Now they're going to get a non-contrast head CT first, and the nurse has to go with them to CT, and then obviously other people if the patient's critical. And that non-contrast head CT needs to happen first. Why is that? What are we trying to see in a non-contrast head CT? You can't really see a clot super well unless it's really big in a non-con head CT, and you can't really see the details very well of that clot. However, you can sure as heck rule out a hemorrhage. So we're trying to rule out a hemorrhagic stroke. That's the only reason for a non-con head CT. Why? Well, if I tried to push contrast in a brain that's hemorrhaged, now you've got contrast all over, everywhere. So that can be really bad. So you don't want to give contrast in a hemorrhagic stroke. So at that point, if we figure out it's hemorrhagic, then everything stops, and then they go to some sort of neurosurgery, advanced treatment, surgery kind of stuff. So if we rule out a hemorrhagic stroke, then they can do the contrast CT. And that's usually kind of your advanced perfusion studies with tons of color, where they can actually see where the clot is. Okay, how far it goes, all that kind of stuff. All right. After CT, this is after CT, we can get this stuff done. Okay. So a 12-lead EKG, this happened to me one time. I actually waited to send a patient to CT and did the 12-lead first. Never, ever, ever do that. Okay. So we want to make sure they get to CT first, and then you can do the 12-lead after. So 12-lead EKG, you want a portable chest X-ray. We want to keep them NPO, okay? And that is because if someone has a facial droop or someone has issues with speech, then that means that they have a cranial nerve involved, and those same cranial nerves that deal with the face movement and the speech usually deal with the ability to swallow. So if you give them something by mouth, even medication, then they're at risk for aspiration, right? And then we want to do some sort of swallow screen. Now in the ER, don't fret, because in the ER, the swallow screen for a stroke is very simple, okay? And we'll talk about that in just a second. Okay, so this is the ER swallow screen. It is very simple. Once they get up to the floor, it's going to be a little bit more complicated, and then speech pathology will take over, okay? So at the beginning, it starts out with, does your patient have a facial droop? Do they have a facial droop? Yes. So then that means that's an automatic fail, and you stop the test. See, I told you it was easy. So then you just chart, patient failed because they have a facial droop. End of, yay, easiest swallow screen ever. All right. Now let's say they don't have a facial droop, so then you go down to the next number, which is speech changes. If the patient has any speech changes at all, right, they fail. Fail, and stop. So you stop the swallow screen right then and there. If their GCS, or their level of consciousness, right, that's measuring level of consciousness, is less than 13, then they also fail, right? And then if they cough, you're going to have them cough, and they're not able to cough on command, or they kind of gag or whatever. So the coughing on command is usually trying to establish, what type of control do they have with those muscles back there. They're again involving our cranial nerves. And then swallowing, we want to know, can they swallow their saliva first? Right? And then you progress to 5 mils or a teaspoon of water. Then you might move up to 10, then 15, then 20. Just kind of see how they go. 9 times out of 10, your strokes will fail right here. Facial droop, check. Bye. No more strokes, no more swallow screen. So it's actually pretty simple in the ER. So TPA contraindications are, obviously you have to get consent to do TPA. So either they need to sign consent. If they're not able to, then a family member. If a family member's not there, then it's implied consent, and then you have to get someone to witness with you. So you and a provider, another nurse, however you want to do it. Okay. So last known well has to be under the 3 to 6 hour mark for most places. So if it's greater than that, then they can't have TPA usually. Okay. BP systolic has to be, if it's greater than 185, they can't have TPA. If the diastolic's less than 110, they can't have TPA. So you need to give them something, right? Usually we give them labetalol to fix it. There's some other drugs that they can use as well. All right, and then intracranial hemorrhage. Obviously, if they have a hemorrhage, they can't have TPA because it's going to make things way worse. If they have some sort of internal bleed somewhere, if they've had intracranial surgery within the last 3 months, if they've had a prior stroke within the last 1 to 2 months, usually some facilities move that around a little bit, but yeah, if they've had TPA, I believe if they've had TPA, and I don't know the exact number on that, but you'll need to find out when they last had TPA, if they had it for their stroke. So, and then intracranial surgery, history of neoplasias, so code for some sort of growth, cancer, malignant, whatever. Arterial venous malformations, if they are on anti-coag meds. It's not an absolute contraindication. Some of them are, some of them aren't. Just kind of depends. You need to make sure that the provider's aware, that kind of thing. Yeah, aneurysms, clotting disorders. Okay, so those are all kind of the reasons that we need to say, whoa, are they allowed to have TPA for this, right? So then we have a mechanism of action of the TPA. So tissue plasminogen activator is what it stands for. The layperson calls it the clot buster. So the TPA binds to the fibrin in the thrombus, right? Then it converts the plasminogen to plasmin. So now we're breaking that fiber, that clot, and then we have fibrinolysis. Okay. Now the TPA dosing is sort of complicated, but once you figure it out, it's pretty easy. So it is dosed in 0.9 milligrams per kilogram. So that's why we need their weight in kilograms, if you remember from before, because we have to dose that TPA. Then that is the total dose. So you multiply that 0.9 mgs by how many kilograms they are. That's their total dose of the TPA. We don't give them more than 90 milligrams, ever. So the max dose is always 90 milligrams. You can't go over that. So it's 90 milligrams, and then it's given in pieces. So it's given in 2 parts, or rather 3 parts. So you give the first 10% of the total dose, which this is the bolus. That's basically what you're doing. And it's being done IV, okay? So you cannot give it without a pump, okay? I guess if you were on a desert island, you'd be able to do it if you didn't have a pump, but if you're on a desert island, you wouldn't have TPA. So TPA has to be given on a pump. It's a very dangerous medication. Obviously, you're doing your double nurse checking, that kind of stuff. It's over 1 minute. So that first 10% of that total dose, right, is going to be given over 1 minute. So you'll calculate your drip rates based on that. And then our remaining 90% is given over 60 minutes on the pump. So you give that first 10% over a minute, and then the remaining 90% over 60 minutes. Now, this is kind of a new thing within the last 5 or 6 years. You know, once you're done with the TPA, how much is left in that tubing? Depending on how long your tubing is, anywhere between 20 to 30, sometimes 50 milliliters. So it's quite a bit of TPA that's not given to the patient, and after a lot of, you know, evidence-based practice and studies were done, they found that if you give the patient the rest of that stuff, you know, if you give them all of the medication, so flush all of that into them from the tubing, they actually have better outcomes. So that's kind of the reason why. So we remove the TPA bottle, so you unspike, right? So you're going to unspike that TPA bottle. We're going to dispose of it correctly in our sharps or whatever glass bottle container we have. And then we're going to keep the tubing. So keep the tubing, don't throw the tubing away. And you want to stop that drip right as it enters the drip chamber and once the bottle's empty, okay? Or the bag. Depends on how your pharmacy does it. Some places it's in a bottle, some places it's in a bag. Okay, now we keep the tubing because we're going to reuse it. This is like the only time nowadays that we ever say, yes, you have to reuse the tubing. Because if you don't, it completely negates the whole thing we're doing here. So we spike a 100 ml bag. So we keep our tubing, right? We've got our drip chamber with our little spiky thing on top, right? And then we're going to take our 100 ml bag. We're going to pull the thingy off, spike that new 100 ml bag, okay? So now we spiked it. And then you don't prime it, right? We're not going to prime it because we're already primed. That tubing's already primed with the TPA that was in there. Then we give that 100 ml NS bag over an hour, 60 minutes, okay? Why do we do this, right? Just like I was talking about, because we get better outcomes. And that's really what this is all about, is better patient outcomes. All right, now there are times when you'll be giving TPA and you need to understand when it's appropriate and prudent to stop it immediately in the middle of the infusion. So and that has to do with the patient's symptoms, okay? You're going to stay with the patient the entire time they're getting TPA. You cannot leave the room. That patient is a one-to-one. So all of your patients will be assigned to other nurses, okay? So you DC it if they have a severe sudden headache. Whoa. Why would a severe sudden headache tell you you need to stop TPA? Well, if they're having a severe sudden headache, they probably are now having an intracranial bleed. And so now you need to stop the TPA because now they have a different problem. So usually we call the provider in the room immediately, and then they'll do an evaluation and they'll probably send them back over to CT. So now we might have a bleed possibly, so then they need to go back to CT, okay? And then we also stop for acute hypertension. So remember how we couldn't give TPA if their systolic was above 185 and their diastolic was above 110? Depending on your facility, it might be 180. So kind of go off your facility's protocols. But in general, if they develop acute hypertension, you got to stop the infusion, right? And so then we have to get that blood pressure back down before you can restart the infusion. So that's, you know, obviously stop it, go get your provider, right? So this is kind of the pattern. We'd stop, get the provider. All right. Now, if they develop acute nausea and vomiting, that could also mean that they're hemorrhaging as well in their brain. And so we just need to make sure we stop, let the provider know. If they have any changes in their LOC, that's kind of bad. That means that you probably have a bleed or some sort of pressure change. And now we have increased now we have an increase in pressure, right? Intracranial pressure in the brain itself. And so then it's pushing on that frontal lobe and on, you know, different parts. And so your patient will not be as awake, alert. They'll have a major change in their mental status or level of consciousness. And that's it. Okay. Push like and subscribe at the bottom if you want to see the next video. Yeah.